All right. Well, once again, welcome to the Iowa Provider Networking Session. And for those of you who don't know me, I am Rose Schaffhauser. I'm the Executive Director for MAMES, and I've been doing it now for 21 years. And so on this line, we have several providers from several different companies, but what I wanted to do, I'm going to throw Matt and Danielle under the bus and have themselves introduce themselves as the MAMES Iowa Board of Directors. So Matt, I am going to, if you can, take yourself off mute and introduce yourself to the group.
Rose, were you talking to me?
Yes, I was. Can you?
I'm sorry. I had someone step in my office. I apologize. I thought I heard my name. You have to start over. I apologize.
Yeah, you're going to run this whole meeting, so go for it.
What's that?
I said you're going to run this whole meeting, so go for it. No, sorry, Matt. I'm just having you introduce yourself to the group as representing Iowa as the Iowa board member and also an executive committee member, if you'd like to.
Yep, I'm Matt Flatt. I've met most of you guys, I think. I work with New Care Home Medical. I'm the exec VP for formerly Hammer Medical Supply, now New Care Home Medical. I work on the board with Danielle from CarePro, and I'm on the exec committee as well. So I'm the Iowa State chair, I guess, right? So.
Yep, for sure. Thank you, Matt. And Danielle, how about you?
I'm Danielle. I'm the director for CarePro Home Medical. Been on the board for, I don't know, a couple of years probably with Matt. Been with CarePro close to 10 years now. We are based mostly out of Cedar Rapids and Eastern Iowa areas for our branches.
Wonderful. Thank you, Danielle. And again, it was depending on the group of how many folks we have. I was going to go ahead and have you all introduce yourself, but for the sake of time and knowing how valuable it is and you know, the stress of having to deal with taking care of your patients at the same time, we'll get right into the meat of why we're having this meeting. So what I wanted to do is, again, introduce everybody that this is your opportunity to ask questions of other providers. For those of you that did register or that did RSVP, we did receive a few questions right out of the gate. And I'm going to just kick it off with one of those questions, and how this is going to work is it's going to be an open back and forth communication. And the more you participate, the more you ask questions or respond, the more you're going to get out of this. So the goal of this whole entire meeting is for me not to talk and for you guys to do the talking amongst yourself. And then I will just jump in, you know, if there's any dead silence or anything like that. So I am going to kick us off with the first question that I received and then turn it over to you all. So one of the questions we got submitted was, how are you handling the lack of inventory available from vendors when it comes to concentrators?
I would just, you know, this is Pat from Unity Point. We've just had to really diversify and go to different vendors. And obviously, when you find them, order in bulk. We're fortunate enough to have several sites across the state that we've shared from back and forth. But as you know, that's a logistic challenge too. You know, we may have, you know, I think most recently we were short in concentrators in Sioux City, Iowa, and we had an excess in Peoria, Illinois. So it's not an easy feat to get it clear across. But, you know, just for example, historically, we were probably more of a Invacare and Respironics concentrator vendor, and Drive has really stepped up and had some available inventory. So, you know, we've just kind of expanded our formulary, I would say, of concentrators that we've purchased.
Thank you, Pat. That's good information. Anybody else want to share what they're doing?
I can add.
Yeah,
go ahead. I can add that we We were primary Invacare in the past too. We did some Respironics, but in the past, I'd say 2 years, we've actually started adding a lot more drive units. We were seeing a lot of equipment failure with our Invacare units. And so we had branched out to drive. We started with their 5s, and then when they rolled out the 10 units, we went to them too. And so we seem to be able to get those in from the drive units right now. So we're not experiencing equipment issues on that side from drive.
This is Craig from VGM. Just a quick question for those of you that have diversified a little bit. Did surcharges from manufacturers factor into that, or was it purely a equipment shortage?
We had done our switch prior to this year. So
Okay.
that wasn't the biggest reason we switched. Like I said, we were having equipment failure issues more than anything. So we thought we needed to look at some different options. Felt like
Non-concentrators, were surcharges a fact? Were those levied by all the manufacturers or just certain ones? I'm not certain.
I only saw it on a couple. I didn't see it across.
Yeah, it wasn't across the board.
Okay.
And Craig, I would say even on the ones that levied the surcharge, it was, you might have been charged a surcharge, but you never got, they were on such a backlog, it didn't matter anyway. So before they ship, they'd say, do you still want it? And I'd be like, well, we got it somewhere else. And plus you're
Yep.
charging me a surcharge. So
Yep.
no, thank you.
Very good.
That was an interesting practice. So I will say pretty frustrated with some vendors because it was more like, hey, we're in a public health emergency. If you want your stuff now, you can pay a surcharge. If not, you go to the end of the line. So it just didn't feel right from some of our vendors.
And Matt, I think you were going to try to say something as well.
No, I was just gonna say, we've been pretty lucky in being able to work from existing inventory and having to buy concentrators on a pretty limited basis. We did in March kind of a project where anything that needed to be rebuilt, any concentrators that needed to be repaired, we had a real big push in March. We were anticipating maybe some failures and getting parts, maybe some delays in getting parts. So we tried to do a big push, and anything that could be rebuilt, we rebuilt. So we've been pretty lucky working from existing inventory and only buying, what we feel like we were short on. So we never really saw a huge wave of oxygen referrals that came from COVID. I'm not going to say we didn't have an increase, but we never saw that huge wave. And maybe that's just demographics and being in an urban area. I think now we might be seeing that increase finally, but I don't think up to this point, I don't really think that we saw a huge wave of O2 referrals. There were some, but we never got blown out of concentrators to this point. So.
Yeah, and we've been hearing throughout our territory that there's several areas that did, they struggled to get them. And so a follow-up question, and again, I think especially in Iowa, but I know Wisconsin had gotten hit hard, where we had one of our members that was calling all over trying to find concentrators. So with that, and maybe this is something in the future, one of the discussions that I've heard from providers are, what are you guys' plans that if you had to buy a bunch of concentrators, obviously they're on short-term, usage. And then, when the PHE is over, is what are you going to do, or what are your plans for all that excess inventory? Anybody have anything or thought about that?
So I thought we were going to sell them all to Nucara for what we paid.
I knew that was coming. I knew it was coming.
I thought he's got big, nice warehouses over there. So I thought, good question, Rose. We talk about that, and even with our CFO, financially, this is one of those impacts that, it's going to linger on for a while. We're going to have more inventory on hand than we probably need. So, luckily, we can cash flow that now, and the hope is that technology doesn't change enough that those concentrators are still going to be very useful to us for the years to come. And like Matt said, we did have to buy some. We got hit, but for the most part, it's been short-term usage. So if you weathered the first storm, we've been able to cycle through. A lot of those COVID patients are, there's just no room at the hospital, or they didn't want them in the hospital. So, they were going home on oxygen. In the next, 30 to 60 days, we were right back out picking it back up. So we had to up our par level, but probably not to the amount that you would think.
Yeah, and with that, there was another question that related to that is, as the increase was happening to some of these folks, they would go to a COVID patient form, to pick up a concentrator, and then they would have to, several of them reported like having special closets or special areas where they would let them sit for a couple of weeks and then do their overall cleaning. Have you guys had any issues with, again, trying to keep the COVID patients separate from the regular patients? And then those regular patients, did you treat all concentrator cleaning as the same, or how did you guys handle that, or are handling that?
I don't think we found it practical for very long to keep a quarantine pile of COVID equipment versus non-COVID equipment. And we do a lot of hospice and a lot of facility business as well, and we found that unfortunately a lot of things weren't reported timely, so you kind of had to treat everything as having been exposed and treat it to that level. So we found it just better to treat things. I mean, in limited circumstances we can of course segregate and do some of those things, but for the most part we treat it all as if it's been exposed, and we go through that process. I think everybody's concerns in March and April are much different than what they are today. And it doesn't mean we're not still concerned. I think we just have a more realistic view of what the risk associated with some of that stuff is now.
Some of our nursing homes and the hospices, they'd actually keep the equipment and wouldn't, quarantine themselves and wouldn't hand it over to us for 3 to 5 days anyhow. So they would almost quarantine it for us and wouldn't turn it over to us until a quarantined period.
So you're not quarantined at all then, Matt, Brandon?
No, not really for the most part. I mean, if at this point we're really, we reached out to a lot of manufacturers and a lot of other providers in March. I say March, but it was probably really April when this thing really got geared up. And we're cleaning it. The cleaning instructions for COVID are pretty much the same as anything else. We feel that public health has kind of ruled out fomites as a really, high cause of spread. So we're really kind of treating it as anything else. I don't want to in any way send the message that we're not taking it seriously and decontaminating the equipment. I think we're decontaminating everything as if it had COVID rather than isolated piles of things. So we're also, our trucks and things like that, we're decontaminating as well. So we're really just trying to, go ahead, Brandon, what were you gonna say?
Well, yeah, it's, we just don't have the space in our Des Moines warehouse. So if we pick up, equipment from an active case, they do a knockdown at the curbside with cleaner, bag it, bring it back, and then it goes directly back in for processing. So it doesn't sit with other dirty equipment. So once it gets back to the warehouse, it goes right back in to be processed. So it's really not, doesn't have the risk of sitting around other equipment. So it's processed right away. But it's already gone through a treatment process at the curbside.
Are some of you guys still quarantining for an extended period of time?
We are right now still, yes.
Are you doing the 3 to 5 days? Is that kind of what you're trying to do?
No, we're actually doing 2 weeks.
Are you really? For everything that comes back in?
It's for known COVID, and that's, you're right. Sometimes you don't know until after the fact. So,
we just, because of the amount of hospice we do, and I think you do a fair amount yourself, you just find out some of those things
yeah.
so late that, I mean, we can't quarantine everything, you know, especially, you know, our inventory pinch didn't come on concentrators. It came on beds, and it's on lift chairs now and things like that. So we can't quarantine every bed, or we'd never be able to set up a new patient. So that was just kind of how, you know, we tried to quarantine initially. It just didn't work out realistically, both for space and just for inventory churn. It was a real challenge, but we feel like we've got a good process now, and we treat things, you know, we have kind of a little assembly line. We treat for, you know, COVID. When we know it's COVID, we obviously are going to go over it again with a, you know, a fine brush, I think, to clean everything off. But in the end, we treat it all the same. So that's kind of what we've been doing.
Yeah, Matt, we're like you. We started to try to quarantine it, and honestly, our concentrators coming back through, we were trying to meet like a 72-hour period, and we were behind anyway. So most of ours was being quarantined for, you know, not being clean for 72 hours anyway when it was coming back through, other than, like you said, Brandon, a spray at the curbside and let it sit. But I would say in TME, you know, we're used to equipment processing, and most of our cleaners all was, you know, would kill COVID anyway, as long as anything else. So we went away from the quarantining, but on like beds and things, we never did either, because we figured, you know, if you spray it down and you're cleaning it appropriately, you should be killing everything on that surface as well. I mean, we did, probably one of the bigger things is we were a little more lenient on returns of equipment and supplies of unused. So we, you know, we put a stop to that, even if it was unused equipment, supplies. You know, sometimes we would have them donate it or that sort of thing. So we stopped taking those things back into the building. So limiting as much as we could back into our building. But as far as our equipment, yeah, no quarantining or anything anymore on that. We probably
At
had
Mercy.
Oh, go ahead.
Oh, no, that's okay. I was just going to say at Mercy One, we are still doing a 3-day quarantine tag on all equipment. Now, but you know, as this evolves, I was curious too whether it was really necessary. So I'm glad we're having this conversation, because there is a desperate need for concentrators in our office. So I'd be anxious to hear the consensus as far as, are we still isolating or not?
It sounds like for us in Unity Point, not really, and CarePro still is, and I don't know about some of the others. So if anybody else wants to weigh in.
Karen or Lisa, how about you guys? What are you guys doing?
This is Karen. Can you hear me?
Yeah, we can hear you.
Okay, sorry. So we are still quarantining our respiratory equipment for 72 hours. We spray everything down at curbside, but then we go ahead and quarantine it for 72. We don't quarantine like hospital beds or like the hard metal, that sort of thing. And then we're making sure that we clean it normally. We take out all the filters, and then we run it through like an ozone machine in a cabinet overnight to kind of give it a little extra step there.
Karen, I'm sorry. Did you say you were doing 3 days? Sorry, it was hard to hear.
Yes, that's correct. We marked off an area in our dirty bay, I guess you call it, and so it all kind of goes in that corner. It's roped off so everybody knows and is aware. And sometimes it's longer than that. It just depends on, you know, how things are going.
So as usual, I'm not the right person to be on this call. But I'm kind of it here at UI Home Care. We don't have, the oxygen and the beds and the stuff that all our vendor partners are doing for us. I'm not quite sure what our warehouse is doing as far as their enteral pumps and fusion pumps. That would be the main stuff coming back in here. And I'm not sure if they've changed their protocols or not. I haven't seen any different areas set up in the warehouse where they would be setting things to the side. And usually they're a little behind on stuff as it comes in the door. It sits in the dirty room for a while before somebody finally decides they need to clean stuff. So, but fortunately, unfortunately, you all are doing our concentrators and beds and other stuff.
Can I ask a question on the billing side? What providers are seeing as far as, the Medicare, if it's a COVID diagnosis, are you guys still getting the testing? Are you pushing them through with just the diagnosis of COVID?
So we have enjoyed the flexibilities of the waivers. But what our protocol is to do as much as we can to qualify the patient like we normally would, and then document what we don't have and why. So the vast majority of our referrals are coming out of UIHC, either inpatient or a clinic. So they've been seen. We have done a couple that were telehealth visits. Some of those maybe had their own home oximeter where the patient was reporting what their SATs were. So we've just we're not making it a free for all. We're trying to dot all the I's, cross all the T's, but we've taken way more short-term oxygen and, diagnosis that we never would have taken before and have had success billing those. And then, like Pat was saying, 30, 60 days later, you're going out and picking up the equipment. And that's not just COVID cases. Like we're doing COPD exacerbations, pneumonias, just to get them out of the hospital and out of that bed. So it's not entirely COVID where we're applying the flexibilities.
Yeah, I would say we're similar with you, Lisa. At Unity Point, we're having good luck on that. What we did do is create, I guess my biggest worry with this is we set somebody up and then the PHE is officially over and then Medicare comes back and says, during an audit. So we've created notes in our billing system if we have build it without our normal qualifications or something is wonky there in our qualifications on putting that note so we can run reports post public health emergency here to see if we need to go back and revisit requalifications at any future follow-up visits. But for the most part, we haven't ran wild with it. We are still trying to push for the requirements, and if they can't give us the requirements, then we accept that patient and then document internally in a note so we can track that later. But have good luck. So far, we just had an internal meeting the other day on to see if we were having any denials on things rolling through, with the KX and the CR modifiers on it. But so far, we have not seen any billing struggles yet.
Are you doing that for any other insurances or just Medicare?
Pretty much with all, we're trying to handle everybody the same, pretty much, but we're putting the note in our internal system on for sure for those Medicare replacement or governmental payers.
So Danielle cut out. I didn't catch that. So Pat, are you saying you're applying those waivers to the Medicare replacement plans too? Because we didn't feel like we could.
I'm gonna have to go back and look. I feel like we were handling them all the same. So yes, because there's so many different scenarios under it. Like you said, did they not meet qualifications, or was the testing done on their own? Was it in ER? Pretty much all COVID is a short term. So yeah, we are basically applying Medicare rules to most of our Medicare replacements.
What about Medicaid?
We've kind of taken the stance, and I guess I haven't had to challenge this much with the mayor group. Like, since things require an auth, we toss it out there and let them decide. But you know, since the mayor group's gotten away from authorizing oxygen, I do think there's something, man, I'd have to look back at my notes, that a mayor group back when they did require an auth for oxygen, that they were waiving that if it was COVID, that you did not have to get an auth if the diagnosis was COVID. I haven't had any traditional straight Medicaid that I've had to deal with.
Yeah.
And this is Rose. Ended up getting my computer's frozen, so I don't dare try to reset anything, or otherwise I'll stop recording. So I'm calling in on a line. One of the questions related to this signature issue is not sure that everybody understands that what wasn't waived was the signature on the assignment of benefits. How are you all handling the assignment of benefits?
We're mailing them and tracking them to make sure we get them back.
For anything we're delivering to the hospital room, we're getting pen and ink signatures on our forms. Things that only our vendor partners are doing on our behalf, we're asking them to get it. And if they don't, like some of our vendor partners use Apacheta and then that's not possible, then we would mail it and track it from here. We're trying to avoid the mailing and tracking because it sucks. But fortunately, a lot of our patients need at least something to their hospital room before discharge. And we have an in-house staff person at the hospital that can do that for us.
That's our biggest, I would say that's our biggest worry about risk, because especially initially, most of our using Apacheta and Brightree, you know, our techs would write, you know, COVID or something, unable to sign due to COVID. So we would document that at that point in time. But as far as we were probably at high risk for audit there, because there was a period of time trying to capture signatures. You know, it just doesn't make sense. We have tried emails too. You know, we utilized a newer system that we're trialing to send AOBs electronically as well.
We're in the same boat, Pat. Until we heard that clarification, we didn't think the signature was required. So we did not go back and find those patients. We are not going to chase that. So if we got audited, we'd have a problem too for that chunk of time.
Well, and we're working real hard through the Medicare councils, and we just sent a follow-up email because so many of the providers are the same boat that you guys are, especially for those providers that have their assignment of benefits on their delivery slips. And so a lot of providers didn't even know that the assignment of benefit wasn't part of that. So you're not alone. We're still pushing. In fact, I sent a follow-up. I work on all 4 Medicare councils, and I sent a follow-up to jurisdiction B, CGS, and they are understanding of the issue, but they had said last week that they're continuing to discuss it internally with CMS, and they're still waiting their direction. So we're going to keep pushing that route. So that, you know, when it comes to time to do audits, that it's not going to hit us all hard, because I think it's going to be, everybody's going to be in the same boat.
Well, also along the lines of your signatures, you also have, it's not have to do with the AOBs, but your proof of receipt of HIPAA documentation. If you, like us, that receipt of HIPAA documentation is on that delivery slip, and if the patient doesn't sign it, you need to obtain proof that they've received your HIPAA documentation.
All right. Well, any other questions regarding the billing side of things for each other? All right. Well, one of the other things we heard from our roundtable discussion in the retail one was on the staffing side of things. It's becoming such a challenge. First question that we received was, how is everyone handling their sick employees that do not test positive? Kicking them out the door?
I think that's a challenging question to answer, because I will tell you, since March, I don't think I've had any situation ever be the same twice. I couldn't really write a book on it because I haven't encountered the same problem twice. I mean, we follow doctor's orders, and I think we follow practical. If someone has COVID symptoms, we keep them out until they either test negative or their symptoms subside. We follow, we take their doctor's recommendation. We wear masks all the time here. So, I mean, the good news is when people do come in, we feel like we help to minimize the risk, obviously, but every situation, we have to treat everything on a case-by-case basis. I mean, don't most of you guys find that kind of and we're in healthcare too. So to a certain extent, we have to be able to do, we're not like a toy store down the road. We can't just close up shop and open up again in January. We have to provide services. So we do our best to minimize the risk. We keep the employees out who are testing positive or who are symptomatic, and we deal with the others on a case-by-case basis. So I don't really have a better answer than that. I don't know if anybody else has got a better answer.
I think your answer is our answer too, Matt. Things changed early and often. Situations change a lot. We utilize our employee health to kind of give us the guidance, as far as the COVID exposure and risk. About the only thing we've done for the non-COVID is really kind of talk with leadership a little bit about, can we be a little more liberal with our attendance policy? Now, of course, somebody's always going to abuse that, but if we're telling them, if you're sick, stay at home, and now they're calling in because they have the sniffles, what do you do? So yeah, we're probably more lenient on attendance policy right now, but obviously, if you're sick, stay at home until you feel better and come back. If you have those symptoms, make sure you're tested. If you're positive, then we're follow our COVID protocol is based on how employee health would guide us. And then we've also had more employees working from home also, so they can continue to work, but from the home environment as well.
That's what I was going to say, Pat. I'm not far enough up the organizational chain to know the decision making behind the scenes, but we get a lot of emails each week. So-and-so's working from home until this date. So-and-so will be out until this date. And so it's a lot of flexibility with that. Obviously, there are some positions that cannot work from home, but there's been a lot of coming and going in that respect, as there's been daycare exposures and family exposures. So not necessarily that the employee themselves is showing any symptoms or illness, but then they just work from home for a period of time before they come back.
And I would say, Lisa, that's what we've seen the most of, knock on wood, to this point, is home household members who are exposed, less employees. But obviously, if you have a positive person at home, we have made a company decision where if you have a household member who is positive or suspected, that you cannot come into work until that's been resolved, according to the Department of Public Health's guidelines. So I know other companies don't have the ability to do that, but we've been able to do that. We have people work from home whenever possible. You're right. We deliver things. Have face-to-face retail. We don't have the luxury of, can't do all that from my living room at this point. So for the most part, we're still open and operating with a limited staff working from home, and then we just treat those, and we deal with them as they come. It's been my crystal ball broke in March. That's kind of, I don't know where it's going, but yeah, I don't know how else we would deal with everything. We can't have a universal policy that'll work for everybody at this point. So
We've handled ours a lot of case by case too, but ours is following the guidelines where if there is exposure, if the employee is exposed to a family member, as long as they are not showing symptoms, they still come to work. So we ruled that out about a month or two ago. Luckily, knock on wood, I did go through a spell of very short staff for a while, but as of yesterday, I think I have all my staff back, knock on wood. So we're sitting better.
congratulations.
So it was a rough time there. Actually, I shouldn't say that. We have a couple out for their kids' schools have gone online. And so I've lost those employees because they have to be home to help the kids to be online for school.
Yeah, thanks, Danielle. That's a good point, bringing that up. Another thing we've had to be flexible on is as those schools have pivoted quickly, we're trying to be empathetic with those family members that are now our employees and teachers as well at home, in having employees, if they need kind of short-term change in schedule, have them kind of sign an agreed form. Okay, you can work from home at this time, or you can flex your hours during this time, but only doing it if we can still meet our the patient needs as well. So that does run into, why can this person work from home and I can't? One person may be able to work a work queue from home, the other person is processing equipment, so obviously two totally different roles. But yeah, I've learned to be a lot more flexible this year.
Okay, you guys go ahead if you have other questions of asked each other. I do know, like on the staffing side, I've had a lot of discussions with members that it's been an extreme challenge to keep up morale. So what are some of the things you guys are doing to keep staff morale up?
I'll just tell you, we failed miserably here, so I have nothing to contribute.
I can share what I shared on the retail thing today. We've tried to do like each week something little for the teams. It is harder because I do have like all my billing in the home, so it's can't be across the board all the same, but it's not as easy anymore of just ordering pizzas and having everybody grab lunch because you don't want all these hands in the same boxes too. So we've gone more to like Jimmy John subs or something. We've done some of those individual servings as possible, or just little individual snacks. But again, we've had to kind of change a lot of our appreciation things that we've done in the past.
Hi, this is Laura with New Cara. What Matt and Terry have implemented for our staff is something so simple but so appreciated by the staff, is casual days. Like the full month of November, where every day was a casual day. And staff just appreciated that so much. Wearing jeans is something that makes people so very happy. So that's one thing. And, we did have lunches brought in, individual lunches for quite some time. But yeah, just little things like a lunch here and there, or allowing an extra casual day has, I think, helped with our staff's morale.
We, when this all started March, April, we all went to kind of lockdown curbside. We went to jeans all the time. And then we started opening up, and it kind of felt like the staff was doing a very good job looking nice in jeans. So we kept it. We never went back to business casual. We've allowed jeans from going forward. So, and it's actually, I think some of them look better now than they did before. So.
So in regards to like those staff that are working at home, do you guys do like team huddles? I mean, did they do anything online that they kind of get an opportunity to have some fun, or how do you guys handle that, the online ones, or
Well,
at home?
no, they don't get to have any fun at all.
They get to dress casual, Rose.
Yeah,
That's what
they get to
it
dress
is.
casual. Everybody-
Pajama days.
Yeah. We, have monthly staff meetings, and so we'll do that via team chat. So they get to see everybody. I'll do team chats with them as a group and them individually as well. But, as far as participating in any of the extracurricular type things that we've been allowed to do, no, they're really not involved in that. Like, we don't buy them lunch or anything like that. Their perk is that they do get to work from home.
Their morale seems quite high, I would.
Yeah.
Versus
Yeah.
much higher than some of the others. So.
Yeah.
I know our billing team has done like a weekly little Zoom calls. I'll see they do online bingo. I saw that last week they were doing it. And so I see a lot of their email responses. I know a small group of them do tea time on Tuesday afternoons for 15 minutes, a quick tea time break. They just chat a little bit as their break. So they do little things throughout the, each week I see something little that they'll throw out there. They kind of created a little fun committee for the home employees to figure out how to do stuff to keep them so connected.
I'll say one of the cool side effects of this is we switched to Office online, a while before, so we had Microsoft Teams and things like that, and it wasn't super well utilized. This has really changed the way that our staff really works with each other and relates with each other. Teams is a HIPAA compliant messaging forum, and they do a lot of messaging back and forth that I think Laura's team sees. We do a lot of meetings that way, and where at first it was pretty challenging, it's really changed the way we do business. And I do see, I can't imagine what it will look like, but I do really see that next year, as things kind of get better as far as COVID wise, I think the way we do business, we'll still see a lot of the changes from this. Rose, it's kind of like with the conference and everything, some of these things that we did out of necessity, but I think some of the lasting impacts will be there into next year. So it's kind of a neat side effect. I think people really like chatting with each other. It's faster than a phone call. They can resolve some things. I'm sure our data usage on emojis is probably quite high, but no, it's a neat little side effect to see that people have embraced the technology and kind of made their lives more efficient. And I think they have a little more fun with it too. So
My group in the billing department, I think we had originally sent 6 people to work from home, and they started just a group chat, including me, with the 6 of them, and good morning, how's your day going type comments. But also, as Matt said, that has opened up the door for all of our staff to utilize that to chat, not only with people who are still working within the building, but the people working from home. And I would agree with Matt that it has been a great tool that we are using to open those lines of communication, and you're not waiting for an email. You don't have to tie up a phone line. I think that has worked really, really well.
Do you guys, I'm sure you haven't thought about it, but are you considering once this PHE is over and certain things like that, where, especially billing staff working from home, are a lot of you thinking that that's going to be your future, or are you just going to still wait and see how it goes?
My opinion as the manager of the department is they will come back to work. And, working from home for us, just, in my opinion, you don't have the camaraderie that you would normally have if they're internal. And, there's just lots of different things to consider when you allow people to work from home. And it just is, to me, a better situation if people are working in the building?
I would like everybody to come back, but I don't think that will happen based on, you know, the structure and our central billing office and things like that. I will say it's forced us to develop productivity measures, better productivity measures that we probably should have had in place before. So you have a little more transparency on what people are doing when either they're, you know, not being directly supervised or, you know, managing themselves at home. So I think people learned as soon as we put some productivity measures on them that there is ways to see, you know, how much laundry they're doing during the day on those breaks, you know, those big gaps in work. And that hold them a little more accountable as well. But Laura, I'm with you. I would love them to come back in because I think there's a lot of other benefits internally to the other team members as well. But I just don't know if that will actually happen.
We've made the decision that we are going to permanently keep them out. We gave them the option. We had a couple that wanted to come back, and so we were able to spread them out enough. So those that want to, at any time they can come back. We actually then just recently drafted policies for it and bought actual software, computers, everything, the phones, and put investment into it because we want, and also to their fairness, they never knew at any time if we'd say you have to come back now. So a lot had not bought nice desks to work at or good chairs. So I think they appreciated knowing this is long-term. They then made those investments because I know some were not working probably in the best chairs and stuff, but I don't blame them for not wanting to buy something knowing they were coming back. So we decided, I have, I think 14 or 15 working in the home. There's a couple roles that we will bring back in that do more intake. We just rotated them for a little bit as we were seeing our numbers with our staffing struggles. But right now, yeah, it's working. We're actually seeing higher productivity with them at home than we were in the office.
I think, Danielle, that's a good point because that's kind of what we've talked about. Ours have been sort of responsive to send people back home. We never kept them home the whole time. And I think the challenge is it's easy to do for a short-term period, but if you're going to do it long-term, you have to do what you guys did. You have to invest in not only making sure their office meets state requirements and OSHA requirements, but making sure HIPAA is preserved. I mean, we have staff members who have family members who work for competitors. So, I mean, you have to always ask, you have to look at all those different situations. So it's just kind of a, we at this point, Rose, haven't decided that it's just a substantial investment. And I think we'd have to do a lot more research to decide if that was really for us long-term. Laura, I do agree. Laura and our fearless CEO, I think, are on the same page. I think that most of our employees will probably come back once the short-term problem has resolved. But for a long-term, I'm open to the idea. I just think we'd have to do more what you did, Danielle. I don't think we could do it the way we're doing it right now. I don't think it would work long-term. What software did you buy? Can you share that? Do you know?
I mean, I'd have to, IT did all of it. We bought laptops from all that were locked down, had monitoring systems on it. They were using, with our Microlab phones, they could do an app on their cell. So they were using their personal cells with our apps. And we were also having, it wasn't built for that traffic. We were having drop call issues. So we decided this is a long-term plan. We had to put that investment. So we bought these port things that they could take their desk phone home now too. And so we've probably, of course we hit a back order on some of it.
Yeah.
I think probably 6 of them so far are set up on the new package that we're getting. I think they just wanted an answer to know so they could put their investment. And we also brought in, we did some ergonomics videos and required trainings for them too, to make sure they're, like you said, for the state and stuff. So we did all those pieces too, and the HIPAA trainings, and had them sign our full policy on it. So. But it also says clearly if they don't meet their measurements, if their metrics aren't being met, or we're having issues that way, at any time they may be required to come in once a month for a staff meeting. So at that point too, they're aware of it.
Craig, are the VGM boys still on the call?
Yeah, I'm here, and John is still on. Yep.
You guys still have a lot of people working from home too, don't you?
Yeah, we
90%.
Yeah, we had brought 25% back, and we're getting closer to bringing some more back, and they ended up sending the people that were in back home. So yeah, probably maybe 10% of total staff is in that building at any given time right now. Everybody's at home. Yep.
That might be something you guys should look at, is for those companies that do want to send people home. It's a little bit bewildering for a small company that doesn't have a lot of experience keeping people working from home. I think, Danielle, you guys probably pieced it together on your own, didn't you?
Our HR had some good contacts at companies
Okay.
that already had people working from home. So she was able to get some copies of their documents, and then we kind of worked just a lot of resources. But yeah, there was a lot of research I know HR and IT had to do for it.
Yeah, from division to division, obviously it's different as in terms of what's needed at home. Like I personally didn't need a whole lot of office equipment provided to me by VGM. I had stuff here at home that I could work off. But I was going to ask Danielle, for what you're doing now in those packages for the phones and the laptops and all of that, what's that like per employee cost to your company for what you're doing to get them up and running versus what it would have taken had they been in the office? Like obviously there's that capital investment no matter where they're at, but what's that new package cost to get an employee up and running at home versus what you were giving them in the office?
I probably can't tell you the comparison. I know I was just looking for the email where he sent pricing for the new package, but I would be able to, I don't know what our comparison is of if they were in the office.
Okay.
I can
That's fine.
get that. Yeah, I mean, that would be good to look at.
Yeah, Danielle, you're a lot farther along than us. So we're, like for me, Rose can tell you, I was outside for 6 months, before I finally ran one of the girls' shrine rooms out and said, okay, I'm going to take over that room. But I don't have the equipment. I don't think, other than our home link, we meet all the requirements on HIPAA, but Craig and I don't need HIPAA requirements. We're not accessing patient files or anything along that line. The question for you guys I do have is on PHE utilization. Do you have the 60-day stockpile? Are you included with your departments of health? Are you, some of you are getting through the hospital, obviously, but what about the others that aren't tied in?
I think we're doing okay on PPE right now. We bought a lot in April. We kind of anticipated the shortfalls, and we bought quite a lot. We still have a lot of orders on allocation, so we get little bits here and there, bit by bit. But I think ours at this point is pretty good, and I think availability is finally loosened up a little bit on. We can get whatever we need. Sometimes what you pay for it doesn't seem to be a fair price, but I call Danielle and bother her all the time, and she's always happy to slip a supplier under my door if I need something. So she's been real helpful. So what we can't find, we've been able to find through reaching out to Jay at VGM or reaching out to Danielle or bothering Rose. So I think for us it's been okay. I don't know about some of the smaller providers.
I was going to mention something earlier, and since you kind of bring it back up, Matt, you said you've got plenty of concentrators, or you didn't see that shortage. Maybe you're going to experience it, while others said, yeah, concentrators are kind of at a premium at our office. I know that we had kind of a listserv. People could, hey, I'm out of concentrators. I can't get any. Does anybody have any extras they could sell or rent or whatever to us, company to company, kind of product sharing? I know obviously some of you compete with one another. Some of you are more apt to do something like that. I just, during this pandemic, I think it's kind of shined a light on how we are a huge part of the answer, and we can help each other be a part of the answer if you're You know, whether it's Des Moines to Cedar Rapids or whatever, if there's a need there to kind of connect providers who are needing equipment or needing to offload some or willing to offload some, if there's something that either we could do as a MAMES thing, whatever. If there's a need there, we'd be happy to look at what some solutions might look like to, you know, pass equipment around and make sure those, I know it can get kind of messy, but at the end of the day, if we're helping keep patients at home and highlighting what we're able to do through this pandemic, I think it's good for the industry for sure.
Yeah, and I'll just piggyback off that, Craig, and that was one of the reasons to have these individual state networking sessions, because I think, you know, as you look at Danielle and Matt and several folks, they network on a regular basis, and, you know, we're always here to help one another out, and so I would challenge anybody, if you are having issues, and I think most of the people on this line, you know that they can reach out to us, and we'll put you out, you know, put you in contact with other folks. But it's events like this that really sets the tone of, you know, to help one another out in a situation. I know with Danielle and the weather that they experienced over the summer, we sent out a call for help, and her, you know, phones and emails did ring and did click in her computer. So it does work. And so with that, I see that we're at our hour. So again, to acknowledge everybody's wonderful time that's spent on this call, is there anything else that anybody would like to ask before we close this session up? And I would like to have a little feedback if you think this was helpful. So I'll turn it over to you all.
Hey, Rose, can you ask about the AmeriGroup Iowa rates? Is
Sure.
Okay, thank you.
Yeah, Danielle, which I think in our Iowa State, our new insurance committee, it's now not a task force, it's an insurance committee. Over the last year, we've been working with AmeriGroup, which, if everybody recalls, about this time last year, everybody got an amendment to their contract, and you had two choices. One was just to go ahead and not do anything, and it would automatically become in effect. And then the other thing is, if you objected, you could turn in an objection, and then you would have follow-up meetings with the AmeriGroup. We've been talking about this issue in the insurance committee meetings, and we had a meeting with AmeriGroup back, I think, early first quarter. Explain the situation that we didn't appreciate. Number one, when the notice went out, not everybody got the letters, not everybody got the amendment, and then the automatic acceptance if they didn't turn around and notify AmeriGroup. And so within our insurance committee, several of our members indicated they did object to the amendment, and to this date, only a few companies have had AmeriGroup reach out to them again. So what Dania is asking is anybody recently been contacted by AmeriGroup on their amendment that they tried getting through last year?
Not on our end.
For example, the rate of a concentrator currently, for those that did object to the new rates, is $184, and they're dropping it to $70 come January 1st.
Yeah, and for the sake of the meeting, we're not allowed to discuss rates, but as and Dania indicated, it is less than Medicare's rates, and typically AmeriGroup has been at or below Medicare rates. And so if anybody's familiar with that or have seen that, and I know that they call it their national fee schedule. So anybody else have experience with that?
Did I miss, how did the notification come? Was it a phone call or a letter, or? I don't mean originally, I mean the new notification. Did I miss that?
Dania?
The original letter came as certified it was just a certified letter and you had like 2 weeks to object.
Yep, I know about that one, but so how were you notified just recently that those changes were going to go into effect?
Her name is Yvonne, and she set up a conference call to let us know that the VP had changed, and anyone who objected, it didn't matter. Basically, you accept their new national rates or you don't contract with them.
Yeah, I think original. That's what I wondered, if you were reached out by Yvonne or, yeah. Yeah.
Our old friend Yvonne.
You know what? I mean,
Yep.
I don't see where we made our choice a long time ago. I don't see where we'd change our opinion on anything. Pat, we'll just send them to you. Is that okay?
Yeah, love AmeriGroup. Just keep them coming, right? Speaking of a public health emergency, I think they give me a public health emergency every time I have to deal with them. But yeah, it's a continuous fight, regardless of who you are. You know, I would say.
To the best of my knowledge, we have not heard any updates on that. I think we've been expecting it for quite some time and haven't heard anything. But
Sounds like maybe be on the lookout for it. If it hasn't come yet, maybe it's going to. But you know, their new VP can say all he wants that, well, they either take it or they don't contract with us. But if ultimately what they're coming to the table with is not doable, it's not like all the movement has to come from the DME side of things. And they might have to make some movement on their side as well. So they still need a network. They still need you guys. Don't forget that.
Yep. Yeah, and I think just bottom line, I know that they from the get-go, I've tried to divide and conquer, and they have indicated to a few folks that actually did speak with them afterwards is that, you know, why are you not signing it? Because everybody else is. And just realize that not everybody else is signing it. So you still have to protect your company. All right. Anything else or any feedback before we close today's networking session?
no, thanks for organizing, Rose, and thanks to everybody for joining. Pat, it's always great to hear from you.
Thanks, Matt. Yeah, thanks, Rose. This was very helpful, I think.
Great. Well, we will look at opportunities, you know, going forward for state meetings. You know, if things like this are helpful, we'd love to hear from you. So any one of you that did participate, if you want to share any feedback with the MAMES office, if you just send me a note at info@mames.com, and we'll talk amongst the board members and, you know, look at maybe doing something like this again. So thank you, everybody, for joining us today, and we will let you go.
Thanks, Rose.
Thanks, Rose. Bye, everybody.
Thanks, all.
Thank you.